I'm a patient representative. I'm not a clinician, but I was diagnosed with prostate cancer 12 years ago. I had various treatments then. I still have my prostate, so I had external beam radiotherapy, high-dose rate brachytherapy, and I had 3 months of hormone deprivation therapy on either side of my main treatments. I've since relapsed twice. I'm patient advocate. I do various bits of voluntary work for Prostate Cancer UK and for Prostate Cancer Research. The two charities are often confused, which isn't very good. And in the course of doing this work, Catherine, my wife, and I began to consider basically what our setting was like, because we work on the basis that I've got the disease in my body, but we have the disease in our lives. So we're part of the context. And the patients exist within a context. And what brought this to a head was when I was having, I think, my first relapse in 2019, I had to do a quality of life questionnaire, which was not I would just have filled these things in without a second thought. There's no problem. I would talk to people about any aspect of my disease whatsoever. It doesn't embarrass me. I'm very used to talking to complete strangers about what could be a rather intimate part. But this is for a purpose, is to enlighten them about the disease and living with the disease and so on. And they're always curious. They're curious about things like erectile function, about digital rectal examinations, all this kind of thing, urinary function, etc., etc. So doing this quality of life questionnaire, which I would have filled in without a second thought, had it been given to me. I spent my time looking at the top of a healthcare professional, I think she was a nurse or a healthcare assistant, looking at the top of her head, because she was leaning down, mumbling the questions, and then filling in things on a Likert scale, and asking me, for example, about nocturia. Did I have to go to the toilet during the night? And giving me a score. What she never asked me at all was how much this bothered me. And I was thinking at the time that when I had my first treatments, I would sometimes get up 10 times during the night. By waking up, go to the toilet, go back to bed, out like a light. Now, I may waken up once, I'm awake for hours thereafter. But according to the EORTC questionnaire on quality of life for prostate cancer patients, I was in a worse setting after my first treatments than I am now. But then my sleep was less disturbed. I had more sleep, basically, even though I woke up and went to the toilet multiple times. So this got us thinking about actually this notion of what it is to be well. And from that, we carried out some work. It's been running for the last couple of years about what is it to be well in the context of prostate cancer and how do people define wellness. Now, this was something which I talked about at the APCCC 2 years ago. This year, I'm going to pick up on the theme of that and say, well, within this wellness, I'll do a quick reiteration of what it is to be well. Within this context of being well, not well, are there things which actually help the patient feel more well, as well as one can be? Because actually, even with the disease, unless it's so bad that it overwhelms you, it's just a part of your life. It's not your whole life. It's an important bit. It's a bit that might kill you, but it's still just a bit. And while there are situations where one might feel that, let's say, with incontinence, if you're incontinent, you cannot forget being incontinent. So you think until you actually are incontinent. And in most instances, those who feel well within that will put on pads. So that's it, change the pad as necessary and get on with life. Those who feel unwell are totally focused on the pad and being wet and so on, and all the unpleasantness. So thinking about this, what things are important besides this wellness under context? And what I'm going to talk about is hope. Now, hope is something which is talked about as an abstract. And one of the problems that we have is that those who are actually designing the questionnaires on quality of life, those who are doing the treating, more often than not, they imagine what it would be like to have, in this case, prostate cancer. And the problem is they haven't had prostate cancer. They don't know what it's like. But equally, even if they had it, they would know what it was like for them. They wouldn't know what it was like for somebody else. But what they do is go in for an espoused theory of action, which Donald Schoen called it. It's an imagining what it would be like. It's a sort of, if I were you. If I were you, here's what I do. Well, actually, you've no idea what you would do. You know what you think you would do, or you know what you think you ought to do, but what you would actually do, what you'd actually feel, you have no idea. I've been asked on multiple occasions by people who said to me, I don't know how I would cope with prostate cancer or cancer in general. To which my reply is, I didn't know either. And if I'd imagined it, I'd have been wrong. Because I would have imagined it in a much more negative way than it happened to have turned out to be. I wouldn't have imagined my character responding to it as it did. Now, within the midst of this, with that sort of setting, but patients actually require hope. Hope doesn't necessarily, it's hope for a cure. It's good, absolutely, yeah. We hope for a cure. I hope that I hope I will live long enough for my cancer to be cured. And I'm absolutely not alone in this. But I also hope that the cure won't be so bad that I wish I hadn't been cured. I'm hoping for a continuing good quality of life. I'm hoping for clinicians to listen to me and to actually attend to what I say. They don't all. Because there's often the situation that even with somebody like me who's very clued up on all of this, I'm an academic by background, I'm an associate professor in education for health, I know what I'm talking about. But even at that, I can feel I'm not listened to. So I would hope that clinicians learn to listen, to be quiet, listen to what the patient says and attend to it. Check understanding. Don't assume to know the answer to the question you haven't actually asked. Actually ask it, but ask meaningful questions. I hope for this. I hope that one of these days the work that I do will get clinicians to actually think, I don't know the answers. I don't know what it's like. I can look in the literature. I can see what, for example, the Stampede trial, which I'm a patient representative, what it's produced in terms of really some game-changing treatment protocols. I don't know what it's like to live this. So if I'm talking to somebody who's going through these, who's on abiraterone, for example, or enzalutamide, who have got a side effect profile which is eye-watering, there's no other way about it, with fatigue, which is horrific. Now, fatigue isn't tiredness. Tiredness, you lay down, you rest, you waken up, you're refreshed. With fatigue, you can be flattened by it, you rest, and you're almost as flattened when you finish resting as you were when you started. So I want people to actually ask the meaningful, my hope is that clinicians will learn to ask the meaningful questions, to actually build the questions on what the patient says. And part of this hope, and it's something I'm engaged in working on bit by bit, is to have meaningful quality of life measures. Not just for trials, because you do one of these quality of life questionnaires for a trial, you do it, it disappears forever. You never see it again. You never get any feedback on what it was like. You don't go to your next consultation. The consultant physician that you see isn't going to say, oh, wow, David, on your last quality of life questionnaire, here's what you said. How is it now? You said, for example, yeah, I have to go for a pee during the night, but it doesn't bother me. Up we go, back to bed, or whatever. Whatever happened to it, never referred to at all. This means I'm wasting my time as far as my quality of life is concerned in doing this. So I hope that this will change. I hope that these things will be developed not as a one-size-fits-all. Currently, they are static instruments. The ORTC, yeah, they've got loads of questionnaires. I do question the extent to which any patient has actually meaningfully sat down and done a proper critique of them. Because there's an awful lot of the, I imagined what it was like, and they never feed back into the patient record. And the work that I did, there was a mini review for European Urology Focus. We actually looked to see if we could find anything that fed back into the patient record. And I don't think we found a single one of these tools that did. Certainly not as a matter of routine. I hope that this will become normalized. I hope it will happen and become normalized. I also hope that we're going to get quality of life tools which adapt to the patient. Currently they don't. They're Procrustean bed. You'll be asked questions which may be of no meaning to you. So, for example, if you have somebody who has got to a stage in their life, a man that hasn't had an erection for years, thinks this is just part of life, on we go, rest of it, this is normal for me, that's how we go. They don't get asked about erectile function. They don't get asked how much it bothers you. Are you concerned about erectile function as a question to start with? That's not there. Rather, it's a question about quality of erection. Is it viable for penetrative sex, and so on we go, orgasm, etc. If you haven't had that in the last 20 years, but you're quite happy with your life, you might be suddenly made to feel you're abnormal. That doesn't fit the patient. And if the patient's actually quite happy with what they've got, they're not concerned. Are you concerned about the erectile function? The answer is no. Why go on and ask them? You've got to ask people how much does it bother. It's the patient's quality of life which is being looked at, not somebody else's. But currently, these tools act as if a sort of, well, here we are doing a trial. We're pumping you full of all sorts of drugs. Even if you're on standard of care, you're still getting pumped full of all sorts of drugs. Or you're in active surveillance, and so on. There's never a sort of, how is it for you? And I think that that's an essential part of it. That's what I'm going to talk about.